Welcome to the 43rd webinar of the Conceptual Basis of Urology course, in which you know that we discuss the art and science of clinical urology. We touch upon some of the contemporary topics on the subject. And tonight, what we are doing is talking about the microbial resistance, the antibiotic resistance, and its impact not only on complex urinary tract infections, GU tuberculosis, but also the impact of microbiome in urolithiasis. In 1928, in St. Mary's Hospital in London, Alexander Fleming, later Sir Alexander Fleming, was working on Staphylococcus aureus species. And he put his Petri dish on the windowsill. It was uncovered. And later, when he looked at the Petri dish, found that the Staphylococcus aureus species were less abundant and they were dying because there was growth of mold on the Petri dish. So where the mold was, the microbiome were not viable. So that mold was killing what he called is not the mold itself, but some mold juice, which results in the death of microbiome. So this was perhaps one of the greatest single discovery in medicine that has impacted the morbidity in disease. The discovery of the Penicillium rubens, which was producing that juice, what Fleming called juice. This was 1928, but that was not the end of the story. Fleming described what was really a discovery of the century. However, he wasn't able to isolate the mycobacterium, the penicillin on a commercial scale so that it can be used as an antibiotic. This work was later done by Howard Florey, was working in Oxford, and by Ernest Chain. Florey was Australian pathologist and pharmacologist, whereas Chain was a German pathologist. And they worked and they isolated the penicillin. It was penicillin G, and then it was used commercially. The three of them were awarded the Nobel Prize in 1945 on this monumental discovery. So obviously we know that antibiotics changed the practice of medicine in the previous century, and it has a significant impact. But as is with everything else in life, this was a double-edged sword to an extent that all major health bodies have started issuing warnings about misuse of antibiotics with resultant resistance. And now we are at the crossroad where development antibiotic is really becoming a very impractical research, because the antibiotics takes a lot of money and time to develop. Once they are developed, they develop resistance very quickly and they go out of market. So this is a major issue. And to discuss this issue tonight, we have two eminent speakers, both from Agha University. Dr. Nausheen Nasir, who is an infectious disease specialist, associate professor in Agha University, and to talk about approach to drug resistance UTI, which is a major issue in Pakistan and elsewhere. And Dr. Ashane Rana, who's a consultant in, again, Agha University, and she will be talking about the multi-drug resistance tuberculosis. So I'm taking the liberty of starting the discussion today on the impact of gut and urinary microbiome on development of urolithiasis. That's an exciting new field. And I'm going to talk a little bit about this. It's a very famous saying that you are what you eat. And clearly, we are seeing that a lot of diseases are because of the way we eat and what we eat. The famous CEO of Apple, Steve Jobs, once said that eat your food like medicine, otherwise, you have to eat your medicine like food. It's a very, very profound statement. Urolithiasis is a major health issue. About 10% of the global population suffers from urolithiasis at one time in their life. It is no longer the disease of the stone belt areas, which were arid, dry, and hot areas where urolithiasis was predominantly. But now, because of the metabolic syndrome and because of what we eat, this is becoming a global problem. So you see it in the coldest areas of the world as well as in the hottest areas. Not only it has a high incidence, but it is an extremely recurrent condition. Nearly two-thirds of the patients recur with another stones in 7 years. So if you have formed stones in the early years of life, you're likely to have many stone events. It has a significant impact on the health-related quality of life. We know that we have been trying, and there's stone research going on for the past over 50 years, and we have looked at metabolic factors and various metabolic interventions. However, we are not very successful. We don't know exactly what causes stone and how can we prevent it. Now, this is a new microbiome. The gut microbiome has been proposed as a contributory factor to development of urolithiasis. And so is the intestinal microbiome. And it is also found to have significant influence on host metabolism, not only by preventing overgrowth of pathogens, by modulating immune response, regulating cell proliferation, and also regulating various endocrine functions of the intestine via neurological signaling. Symbiosis is a condition where a healthy gut microbiome acts synergistically with the host, metabolize and produces beneficial effects. Whereas in exchange, the microbia are housed in a hospitable intestine where they get their food. The opposite of which is dysbiosis. Dysbiosis is a condition which results in various diseases like Crohn's disease, ulcerative colitis, asthma, type 2 diabetes, depression, and anxiety. So all these factors are now related to development of dysbiosis. And this is due to the loss of health protective bacteria and or results from the overgrowth of disease-producing bacteria. Now, one of the first evidence of this came from the early use of early antibiotics in early years of life and development of urolithiasis. Because early years, you use antibiotics, you killed your good bacteria, and you replace them with bad bacteria. Urolithiasis is a complex condition. And this is a little schematic diagram looking at how various risk factors result in development of kidney stone disease. So antibiotic or diet-induced dysbiosis would result in disruption of intestinal microbiome. Now, this would produce recurrent kidney stones and also increases the risk of development of new stones once the stones have been cleared. On the other hand, the dysbiosis of the gut results in also the urinary microbiome to be affected, which also results in stone formation. Urinary tract infections, which can be due to dysbiosis of the urinary tract, can result in urea-producing organisms, which can form staghorn stones and various types of other infective stones. and also it complicates the stone management. One of the important things which has come up in the recent years is the bacterial biofilm formation. And bacterial biofilm formation is also associated with stone recurrence and increased antimicrobial resistance. So it was precisely described very recently, only about more than 35 years back, by Whipps, who called gut microbiome as a characteristic microbial community occupying a reasonably well-defined habitat which has distinct physicochemical properties. Now let's look a little bit onto how the urinary microbiome affects development of kidney stones. We know that even in non-infective individuals, the urinary tract is not sterile, and there are various bacteria present in the urinary tract. The composition of the urinary tract microbiome is affected by use of antibiotics. So this would result in decreased Lactobacillus crispatus species and increase in the E. coli or Enterococci species. And this would result directly in formation of stones. The metabolites, which are highly abundant both in calcium phosphate and calcium oxalate stones, results in quorum sensing molecules that are involved in biofilm. So quorum sensing molecules are cell to cell or bacteria to bacteria communication, which can affect the biofilm formation. And again, as I've said, that the biofilm formation is involved in increase in stone disease. And it is very clearly seen that it is high in stone former versus non-stone formers. This is the list of the healthy versus unhealthy microbiome. On the right-hand side of the screen is the healthy group of microbial in the urinary tract, which are anti-lithogenic, whereas on the other end is Enterococci or E. coli, Staph, Shigella, Pseudomonas. They're all species which can potentially result in complex urinary tract infection as well as stone formation. Now, what is the mechanistic pathway between the disturbed microbiome and kidney stone disease? The dysbiotic gut microbiome is proposed to cause three major effects. Number one, it decreases the enteric oxalate degradation, and we know that vast majority of the stones is because of hyperoxaluria, which forms the most common stone, which is calcium oxalate. A decrease in short-chain fatty acid, particularly butyrate synthesis, which also affect the oxalate degradation, and decrease in vitamin synthesis. Now, we will talk a little bit in detail about all these three mechanistic pathways and their association with kidney stone disease. Let's look at this interesting model. This is an overall model of antibiotic-induced changes to the microbiome that results and influences the risk of nephrolithiasis. So if you look at this diagram, the use of antibiotics would result in gut microbiome getting disturbed and development of dysbiosis. The dysbiosis would result in decrease in the oxalate degradation, so increased oxalate absorption and hyperoxaluria, decreased in the short chain fatty acid, and uric acid metabolism getting impacted. Now, all this would result in intestinal barrier functions, which is affected, which result in decreased permeability. On the same end, it also impacts the liver function or liver metabolism with increased cholesterol and bile acids, which obviously results in the metabolic syndrome and subsequently impact the systemic solute load on the body. This increased systemic solute load would be high oxalate, increased uremic toxins, increased cholesterol and bacteria. And all this would result in systemic or local inflammation. And we know now the modern medicine is looking at the pro-inflammatory factors as the etiology of most diseases, from coronary artery disease to stone formation. So the kidney stones will form because of all this impact, and this is due to inflammation resulting from the decreased short chain fatty acids, increased reactive oxygen species, increased oxalate levels, and biofilm associated calcification. And these calcification, which we sometimes call the Randall's plaque, would be resultant would result in inflammation and stone formation. A parallel pathway is the urinary tract microbiome dysbiosis, which again would result in decreased lactobacillus species and increased Enterobacteriaceae family, again resulting in the same phenomena of stones. Now, if the things are so clear, and Oxalobacter formigenes, which is the main factor which is responsible for degradation of oxalate, if we supplement that with probiotics, meaning that if you give to hyperoxyuric patient, and this study was published a few years back in urolithiasis by Milner and colleague, that if you give probiotics for primary hyperoxyuria in a phase 2 and 3 clinical trial, however, authors did not find benefit in hyperoxyuria or development of kidney stone disease. So what was the conclusion from the study? That single species enrichment is unlikely to be a successful strategy to treat microbiome dysbiosis in kidney stone disease patients. So oxalate degradation not only is responsibility of Oxalobacter formigenes, but there are other bacterial network which metabolically support each other. So other work which looked at not only lactobacillus and bifidobacterium species, this is the work reported in British Journal of Urology recently, has shown that there is significant reduction or trends towards reduced urinary oxalate levels in patients who've received lactobacillus and bifidobacterium along with Oxalobacter formigenes. And it results in decreased levels of oxalate. However, the clinical impact is not clearly demonstrable at the moment, and its impact on decreasing the kidney stone disease is not established, at least in clinical trials. Now, this is about Oxalobacter and its impact on the oxalate absorption or degradation. The other pathway is that of the short chain fatty acids. Now, short chain fatty acids are also responsible for oxalate degradation. So bacterial fermentation would result in production of propionate, acetate, and butyrate. And butyrate is predominantly used as an energy source. However, if the bacteria producing the degrading the fibers into the short chain fatty acids are decreased in abundance, this would result in decrease in the butyric acid levels, which increase superoxide dismutase and decrease in the reactive oxygen species. And as a consequence, this can also have an impact on stone disease. So microbial fiber fermentation coming from the fecal bacterium, Prosnetzi or Rosiburia and LSTP species, etc. Whereas the butyryl co-synthetase and resulting stool butyrate levels were significantly lower in individuals with kidney stone disease. The anti-lithogenic factor, which is the oxalate transport pathways and the anti-inflammatory effect of these short chain fatty acid, is lost if these species are degraded or their abundance is less in the microbiome, and this would result in increased oxalate transport and inflammation, both resulting in urinary tract infection, urinary tract stone disease. So how the diet and medications impact gut dysbiosis. This results from development of both kidney stone disease, but also the diabetic nephropathy. So either diet or misuse of antibiotics would result in gut dysbiosis, decrease short chain fatty acid, increased lipopolysaccharides, and decrease uremic factors. And all this can result in kidney stone as well as diabetic nephropathy. The third thing that we have talked about, besides the oxalate degradation and the short chain fatty acid, is the vitamin metabolism and its relevance in kidney stone disease. So we have some mechanistic pathways, but we don't know for sure how the impact on vitamin production, which is also one of the function of your gut microbiome, can affect kidney stone disease. So these are some of the putative mechanisms. Its impact on urolithiasis. Systemic effects could be with vitamin C or E and K2, and they can all result in soft tissue calcification, which can result in stone formation. Its impact on liver with B6 cofactors and alanine glycoxylate, aminotransferase mediated degradation of glyoxylate to glycine instead of oxalate. So this obviously would again result in increased oxalate levels with subsequent impact on stone disease. Also impacts the immune system, which are also responsible for development of kidney stone disease. This is an interesting diagram. And if you look at the algorithmic pathways in this cartoon, you see that if there is decreased Roseburia species, decreased LSTPs, and increased Fusobacterium, this would result in decreased butyrate level, so butyric acid, or increased butyric degradation. Now, the decreased butyric barrier function coming from the low short chain fatty acid result in increased intestinal oxalate excretion and with systemic oxalosis. Similarly, decreased species of mucinophilia or processenzae would result in vitamin effect on vitamin production. And these vitamins, as we have just shown, also result in stone formation by increasing oxidative stress and inflammation. The third pathway is the famous Oxalobacter formigenes pathway with low Oxalobacter, low Lactobacillus, and low Bifidobacterium species, which is your good bacteria, and their decrease would result in decreased oxalate degradation and subsequent stone formation. So how we can move on from here? Is there any treatment options available with these probiotics? Well, prebiotics, postbiotics, or fecal microbiome transplantation. So these are all the four various ways of changing your gut microbiome back from dysbiosis to symbiosis. However, the clinical impact of these have not been clearly demonstrated so far in research. So in what is the future, individual at risk for kidney stone disease may get gut microbiome sequencing rather than metabolic workup, specifically analyzing individuals with microbiome composition together with metabolomic studies. Treatment could be with probiotic, prebiotic, postbiotics, or fecal microbial transplantation. Now, this is an interesting area which is done by colonoscopy, in which you take the microbial load from healthy individuals and implant it into the gut of patients suffering from dysbiosis. The antibiotics can decrease the abundance of oxalate degrading bacteria, short chain fatty acid, uric acid degrading bacteria, and bacteria that reduces the risk of dyslipidemia or chronic inflammation. And all this can result in stone disease. And they can also increase the abundance of known prolithogenic bacteria and biofilm-forming uropathogens. So in summary, there is an intriguing association between antibiotic use, disturbance in the microbiome, and the resultant urinary tract infections and kidney stone disease. Microbiome dysbiosis is closely related to the etiology of stone disease. Microbiome interventions can be translated to demonstrable clinical efficacy, and this is something that really needs to be proven in the future research. Simple dietary or supplementary based approaches that could apply to the future for prophylaxis of treatment of kidney stone disease. So I'll stop here and I'll unshare my screen. Please post your questions. On the chat box, and I will address them accordingly, and all the other faculty. So I'll unshare my screen, and I'll request Dr. Nausheen Nasir to start sharing her screen. Sorry, stop share. Dr. Nausheen, the screen is yours.
Assalamu alaikum everyone. I hope I'm audible and you can see my screen.
Yes, you're audible and we can see your screen.
Bismillahirrahmanirrahim. First of all, I would like to thank the organizing team for inviting me to talk on this important topic. And I think it is the need of the hour as well. We are facing, what we call is the parallel pandemic or the syndemic of antimicrobial resistance. And to give a bit of a perspective, so the presentation is going to go over the introduction to antimicrobial resistance. I will be doing some of the definitions of UTI and asymptomatic bacteriuria, some general management considerations, and then we will go on to discuss the management of some of the common multi-drug resistant organisms that we encounter in our clinical spheres. And to give you a little bit of perspective, this was a case which was referred to me from Bhavalpur. This is a 45-year-old male who presented with a history of high-grade fever and right-sided flank pain since 1 week. Prior to a month, he had been treated at a local hospital for renal colic, and he had been prescribed ciprofloxacin for 2 weeks prior to this. And one of our residents there told me about this patient and that he was in septic shock, and they had started him on meropenem, and they had sent off the cultures, and the culture report looked something like this. And previously, while we used to see something like this very uncommonly, now we've started to see this quite frequently, and it is quite alarming. And at this point in time, we also shake our heads as to what needs to be done at this point in time. So AMR is a big challenge. It's an escalating global public health challenge of the 21st century. It is a natural evolutionary response to antimicrobial exposure, during which the microorganisms, they acquire the ability to resist antimicrobial drugs, and that leads to the expansion of resistant pathogens, and then they transfer their resistant elements to other pathogens. And the majority of the problem exists in the sub-Saharan Africa and South Asia, and 1.2 million people die worldwide every year. It is estimated that by 2050, the death toll would be a staggering 1 person every 3 seconds if we do not tackle this problem now. So everybody is advised to advocate for something that drives, something which is a driver of AMR, which is human antimicrobial misuse or overuse. So we have to advocate for judicious antimicrobial use in order to prevent this pandemic from occurring. If you look at the global antibiotic consumption, the trends of antibiotic consumption are increasing While they are steady in high-income countries, they are increasing in the low and low-middle-income countries. And Pakistan ranks third amongst the low and low-middle-income countries. So the problem is much more severe in Pakistan. And though this data is old, recent reports have shared the same estimates. So let's go over the definitions of urinary tract infections. I'm sure the audience here is familiar with the terms of uncomplicated and complicated UTIs. Uncomplicated is UTI which occurs in a normal unobstructed genitourinary tract. There's no history of recent instrumentation. Symptoms are confined to the lower urinary tract. Predominantly occurring in immunocompetent people and in non-pregnant females. Complicated UTIs are those that occur in association with a structural or functional abnormality of the genitourinary tract, or any UTI in an adolescent or adult male, people who are immunocompromised, who have a foreign body, people with prostatic disease, strictures or tumors, and pregnant females are known to have complicated UTI. Then there is a terminology which is asymptomatic bacteriuria, and it is defined as patients in those in whom there are no indwelling catheters. It's a 10 to the power 5 colony units in a voided urine specimen without any signs or symptoms which are attributable to UTI. For women, 2 consecutive specimens should be obtained, preferably within 2 weeks, to confirm the persistence of bacteriuria. And for men, this can be a single urine specimen which meets these quantitative criteria. Patients who do have indwelling devices, they often have multiple organisms isolated from the urine. And we should recognize that if it is present in lower quantitative counts, it likely represents contamination of the urine specimen from organisms which make a biofilm along the device rather than true bacteriuria. So when is screening and treatment recommended for asymptomatic bacteriuria? The first and foremost condition is pregnancy, because there is a 20 to 30 fold increased risk of pyelonephritis, premature delivery, and low birth weight among the newborn. So this is one of the indications, and the other is urological procedures such as TURP or bladder ureteroscopy, including lithotripsy, percutaneous stone surgeries, or any surgeries in which mucosal bleeding is anticipated. However, there are certain other urological procedures that do not breach the mucosal lining. For example, uncomplicated catheter removal or exchange, diagnostic cystoscopy, or removal of internal ureteric stents. They are considered low risk for infectious complications. So the screening and treatment is recommended for these high risk procedures. And what is recommended is that the urine culture should be obtained prior to the procedure, and targeted antimicrobial therapy should be prescribed rather than empiric therapy. It should be a short course rather than a more prolonged antimicrobial therapy, and at least 30 to 60 minutes prior procedure, the antibiotic should have been administered. And the American Urological Association also advises that clinicians should not perform a post-treatment test of cure of urine culture in asymptomatic patients. Talking about the general management considerations, so approach to a patient who is presenting to you with signs and symptoms of urinary tract infection, and at the time when you are considering empiric treatment, you should ask the patient about previous organisms that have been identified and the associated antimicrobial susceptibility pattern for that patient in the last 12 months. And which antibiotics has he been taken within he or she has been taken within the past 3 months? What are the local antimicrobial susceptibility patterns? So I'm sure you must be aware of the antibiogram that is published from the microbiology for the institute, and each institute has their own institute has their own patterns as well. So we don't have large prevalence data, large data sets for susceptibility patterns, but we should look at our antibiograms for the most likely pathogens. And the important thing is to recognize infection versus colonization, because a lot of the times these patients are colonized because of the presence of catheters because these organisms, they make biofilms around these. So you have to understand the difference between infection and colonization, particularly in organisms such as Pseudomonas aeruginosa and Acinetobacter baumannii, which are known to colonize and not cause symptoms. Duration of therapy should not differ for the infections caused with resistant organisms compared to those which are caused by susceptible organisms. And generally, the duration should consider the host factors related to the immune status, the ability to attain source control, and general response to therapy should be considered. And usually, the treatment durations for uncomplicated pyelonephritis have now been reduced to 7 days if it is uncomplicated pyelonephritis, and it can go up to 14 days depending on the defervescence of symptoms. Whenever possible, you should attempt to transition the patient to oral therapy. If the criteria is met, the organism is susceptible to an appropriate oral agent, patient is hemodynamically stable, and you have achieved reasonable source control, and you do not have a concern around insufficient intestinal absorption, patient does not have a GI illness as well. So now coming to the common gram-negative resistance categories, and these are the ones that have been defined by the Infectious Diseases Society of America. There are the ESBL, or extended spectrum beta-lactamase producing enterobacterials, the AMP-C beta-lactamase producing enterobacterials, and we'll talk a little bit about all of these. Carbapenem-resistant enterobacterials, carbapenem-resistant Acinetobacter baumannii, difficult to treat resistant Pseudomonas aeruginosa, and Stenotopomonas maltophilia. So these are the 6 categories in which these gram-negative are defined. So what is ESBL producing enterobacterial? So ESBLs are basically enzymes that inactivate most of the penicillins, the cephalosporins, and aztreonam. And any gram-negative organism that has the potential to harbor these genes is considered to be an ESBL producing enterobacterials. Most prevalent in E. coli, Klebsiella pneumoniae, Klebsiella oxytosa, and Proteus mirabilis, which are the common organisms causing urinary tract infections. So often these are not sequenced, or we don't have whole genome sequencing to see the ESBL genes, but instead non-susceptibility to ceftriaxone is often used as a proxy for ESBL production, and we know that our region is highly prevalent for ESBL producing enterobacterials. So what the guidelines recommend is that for uncomplicated cystitis, the first line of treatment should be nitrofurantoin. And so these are, while these are not, the guidance do not recommend in line with empiric treatment, but we know that for empiric also, we use nitrofurantoin because of good susceptibility of the ESBL enterobacterial. So nitrofurantoin, and then trimethylprim sulfamethoxazole, or otherwise known as Septron, if our local resistance rates are less than 20%. So unfortunately, ours are higher than 20%, so we do not recommend it as a first line, but nitrofurantoin is a very important first line agent for our uncomplicated cystitis patients. The alternatives are single dose traditional aminoglycosides, and by traditional I mean amikacin and gentamicin. And oral fosfomycin, which is recommended for E. coli infections only. It is not effective for Klebsiella infections. In fact, because of the presence of the FOS-A gene, which inactivates fosfomycin in infections caused by Klebsiella. So it is no longer even reported in the sensitivities, if I remember correctly, from recent lab directive. Then there are certain regimens to avoid. So while ciprofloxacin or levofloxacin are very effective antibiotics for urinary tract infections, there are increasing reports of severe adverse events due to these antibiotics. And so these have now fallen out of favor unless there are no other options available. In fact, we also see a very high degree of resistance with ciprofloxacin or levofloxacin, and so we don't even consider it in the first line treatment regimen in the local context. Then amoxicillin clavulanate and doxycycline as well. So the reason for these being preferred agents, so nitrofurantoin is very effective, low resistance, limited systemic impact. Septron is preferred because if it is susceptible, it has a very high efficacy. And fosfomycin is as a single dose option for E. coli with the long urinary activity is preferred. But fluoroquinolones, there are concerns for resistance and significant side effects. Carbapenems, although effective, but overuse risks the resistance if they are reserved for more complicated infections. Amoxicillin clavulanate has higher failure rates against ESBL E. coli, and they have unreliable efficacy, so they are no longer recommended for even uncomplicated cystitis. And doxycycline, because of its poor urinary excretion and insufficient evidence of efficacy, it is not recommended. Now, coming to the ESBL-E complicated UTI or pyelonephritis, the first line are the carbapenems. So meropenem, imipenem, ertapenem. If, however, sensitive, then trimethoprim sulfamethoxazole, ciprofloxacin or levofloxacin can also be used for complicated UTI if you do not have a better option. And alternatives include a full course of aminoglycoside. So this is not single dose, this is a full course. And among the newer agents is plazomicin, which is a next generation aminoglycoside antibiotic with good urinary penetration. Regimens to avoid are nitrofurantoin because it does not penetrate the renal parenchyma. So in upper urinary tract infections, it is not recommended. Amoxicillin clavulanate and doxycycline I already spoke about, but the surprise here is piperacillin tazobactam. So previously, piperacillin tazobactam was the first line antibiotic for ESBL-E complicated UTIs, but it is recognized now that it has significant problems with its efficacy, PKPD related issues. And so while it is recommended in the guidelines that if you have started a patient already and the patient has shown signs of improvement, you can continue. But as a first-line regimen, should avoid using piperacillin tazobactam because of its inconsistent efficacy and high failure rates compared to carbapenem, particularly in bacteremic complicated UTIs. So over here, I have summarized carbapenem's gold standard for severe infections and for resistant strains. Trimethoprim sulfamethoxazole and fluoroquinolones are effective if their susceptibility is confirmed because they have good urinary and renal tissue concentrations. Aminoglycosides are effective for the MDR strains. They have high urinary concentration, so generally reserved for more severe cases. And basically, the issue with aminoglycosides is that their toxicity prevents us from using them very often in presence of other better options. Now, MC beta lactamase producing enterobacterial. So these are the ones that are, those that gram negatives that become resistant, although they are initially not resistant, but on therapy, they can acquire resistance. So these are Enterobacter cloacae complex, the Klebsiella aerogenes, and Citrobacter fluendiae. I won't talk a lot about them. But in these patients, we should avoid, although we may see sensitivity to ceftriaxone and ceftazidime, we should avoid these because once the organism is exposed to these antibiotics, it becomes resistant. So it's called inducible beta lactamase production. It makes the enzyme that confers resistance. However, cefepime can be used for moderate risk organisms, and the rest of the treatment guidelines are similar to how we deal with the extended spectrum beta lactamase producing enterobacterials. Now, the bane of our, most of our ID physicians for us is the carbapenem resistant enterobacterialis. And this is because it has a wide variety of resistance mechanisms. There are those that are produce the carbapenemase enzyme, which renders the drugs ineffective. And then there are those that do not make the carbapenemase enzyme. So the treatment is different for both. Sometimes you see a strange strange susceptibility report where you see ertapenem resistance, but you see meropenem and imipenem sensitivity in an enterobacteriaceae such as E. coli and Klebsiella. So those are usually thought to be carbapenemase negative CREs. And in those, you can try a higher dose and prolonged infusion with meropenem. And that is the only indication for extended infusion meropenem treatment for urinary tract infections, in which they exhibit susceptibility to meropenem and imipenem, but they are not susceptible to ertapenem. But for CRE uncomplicated cystitis, we again are lucky if we have fosfomycin, nitrofurantoin. But the alternatives that are there are ceftazidime, avibactam, colistin. Again, fluoroquinolones is susceptible, or aminoglycosides. The regimens to avoid again is piperacillin, tazobactam. Typically, it is also resistant if it is a carbapenem resistant E. coli or Klebsiella. Tigecycline and eravacycline have poor urinary penetration, and so does polymyxin B. So although colistin is also a polymyxin, it's a polymyxin E, and it still has some urinary penetration, not the best drug. But polymyxin B is definitely not to be used in uncomplicated cystitis. Then for complicated urinary tract infections or pyelonephritis, if the patient has sensitivity, susceptibility to ceftazidime, avibactam, it is the drug of choice. Other than that, there are drugs that are not available to us but have been out there in the West for a very long time, highly expensive and very difficult to acquire in Pakistan. So meropenem, vaborbactam, cefiderocol. But our problem is a little bit different. Like I mentioned, the carbapenem resistant enterobacteriaceae are of very different types. In the West, they are predominantly KPC producing, but in us, with us, South Asia, India, Pakistan, they are the NDM or metallobeta-lactamase producing carbapenemases. So in our population, we don't see very good sensitivity, susceptibility to ceftazidime, avibactam. So in this situation, the recommendation is to use ceftazidime, avibactam plus aztreonam. Aztreonam, again, very difficult to acquire and very sparsely available in the country. And usually we have had patients import from Turkey and from India and other parts. If susceptible, again, fluoroquinolones or Septron DS would be some of the options. And alternatives, although the guidelines do not talk about these. So aminoglycosides guidelines are not generally very happy recommending these, but obviously when you don't have any choice, then you should use colistin and intravenous fosfomycin. The guidelines do not mention at all. And the reason for that is colistin is a very unfortunately a poor drug. It's not and it's not been increasingly used in the West. IV fosfomycin is used more in Europe. The data is from Europe, and it has not been used in the US. And unfortunately, we do not have data from South Asia, from India, to support its use. But these are last leg, salvage treatments, which are considered to be salvage treatment and one of the last resort antibiotics. Again, regimens to avoid phospho-nitro, and I've already shared why they need to be avoided. Then we come to the difficult to treat resistant Pseudomonas aeruginosa. Its resistance is more complex, and it has several different mechanisms. Resistance to one antibiotic does not necessarily mean resistance to others. So you must have seen sometimes the susceptibility to piperacillin tazobactam is there, but it is not sensitive to meropenem. This is because it has various different mechanisms of resistance. The preferred treatments include, for the one that is available in Pakistan, ceftazidime, avibactam, but other than that, ceftolozane, tazobactam, and imipenem, cilastatin, relebactam. Unfortunately, the other drugs are not available here, but they are preferred treatment regimens. And there are several treatment challenges that exist because it is difficult to predict the resistance. There are delays in getting susceptibility data. and there are limited clinical trial data available to guide therapy. So for us, predominantly, we are left with colistin for the most part to treat these infections. And we have ceftazidime avibactam if it is sensitive to that. And this is also variable. We see variable susceptibility patterns with ceftazidime avibactam. And if it is sensitive to either the quinolones, then those can be given. From among the aminoglycosides, we can give tobramycin or amikacin, but gentamicin is not recommended. And that is an important thing to consider. Again, phosphomycin and polymyxin B are not to be used for Pseudomonas aeruginosa. There is inherent resistance in case of phosphomycin and should not be used. For carbapenem-resistant Acinetobacter baumannii, there are individualized treatment regimens, but you should remember that the one thing that we need to do is include a sulbactam backbone. And you must have seen in the last 1 year, we started using a lot of cefoperazone sulbactam because of this guideline. And it is important to use it despite that there is no susceptibility reported. And this is true from several clinical trials that have been done in the West. And then you have to combine it with at least one more in vitro active antibiotic. Usually in our case, it's colistin or a tetracycline derivative such as tigecycline. And if tigecycline is being used, it has to be used in higher doses. So the suggested regimens is high-dose ampicillin sulbactam or high-dose cefoperazone sulbactam, so something which has sulbactam backbone, along with another active agent like polymyxin B or colistin, minocycline or tigecycline, and then cefiderocol, which is not available here. And it is important to note that previously we used to do a lot of combination therapy with meropenem, and that is no longer recommended in the guidelines because the data suggests that there is no improvement in mortality or outcomes if we use combination therapy. Last but not the least is Stenotrophomonas maltophilia, particularly in patients who are immunocompromised, and there's no clear first-line treatment regimen, but a combination therapy is preferred. The claim to fame is that they are intrinsically resistant to meropenem. So you usually see that this organism in those patients who have had healthcare exposures and who have been on prolonged treatment with meropenem. And in these patients, then we have to use two of the following agents, either minocycline or with Septron or levofloxacin with Septron. And then, if we have ceftazidime avibactam, then we combine it with aztreonam. So I know that a lot of the urologists prefer to use aminoglycosides. It is quite effective for urinary tract infections, both complicated and uncomplicated. The only problem is the monitoring of nephrotoxicity and ototoxicity that limits its use. And this is a summary that you can see from this slide that has, the medications that are available to us. I have compiled them into this summary, taking the local context in consideration. These are my references, and I'm very happy to take any questions. Thank you.
Thank you very much, Nausheen, for a very comprehensive talk. Because of the time constraints, we will move on to the next presentation. There are a few questions in the chat box for you, and you can answer. So thank you. I think you have provided a very practical approach and the scientific basis of multi-drug resistance, UTI. We move on to our last presentation of the evening, and this is by Dr. Roshane Rana. She is a consultant urologist at Aachen University, and she's going to talk about MDR tuberculosis, which is also a major, major issue. So over to you, Rana. You are muted.
Yeah. So am I now? Yeah. So Dr. Hamad has already introduced my topic. So this is something we don't really much talk about as urologists. Genital tuberculosis in general, and in specific the MDR. So let's first talk about the not moving. Yeah. So what basically is MDR-TB? So the definition itself is important firstly. So when we talk about MDR-TB, that we know that the tuberculosis for the treatment of TB, we use 4 drugs. And if the strain of TB is resistant to isoniazid and rifampicin, then it's labeled as multi-drug resistant. So out of the 4, isoniazid, rifampicin, pyrazinamide, and ethambutol, if a strain is resistant to isoniazid and rifampicin both, then it's labeled as MDR. So there are other forms of resistance also, but I would focus here on extensively drug-resistant TB, which is again, fortunately, a rare type in which the strain is resistant to isoniazid, rifampicin, fluoroquinolone, or a second-line injectable, or the newer agents, bedaquiline or linezolid. So I'll explain all of these agents later on. So globally, the incidence is 135 cases per 100,000 population, with nearly 1.25 million people dying. These are recent WHO statistics from year 2023. Asia, Africa, and Eastern Europe, they remain the region with highest burden. India, China, Indonesia, they nearly make 40% of the global TB burden. So in Pakistan, nearly 500,000 cases are reported each year, with 15,000 people developing drug-resistant TB, and Pakistan is ranked 5th among high-burden countries worldwide, and it is 4th in ranking in terms of MDR-TB globally. So we know that the most common and prevalent form of TB is the pulmonary TB. However, almost 45% of the patients, they do have extrapulmonary involvement, and in those patients, the urogenital tract is one of the most common sites. So the urinary tract is more commonly affected than the genital tract. The GUTB can result from a primary pulmonary infection, or it can result from reinfection of an old infection, which can even happen after decades. There are various risk factors to it, diabetes, old age, low BMI, oncological comorbidities, and immune suppression in general. So the risk of reactivation is estimated to be 15% during one's lifetime. So what are the causes of drug resistance? So it can be primary, where there's a person-to-person transmission of a drug-resistant bug, or it can be secondary, which is also called as acquired resistance, which develops basically during the treatment of TB. And this happens because of inappropriate treatment regimen, lack of compliance. It also happens because of shortage of essential drugs and use of substandard drugs. So testing and diagnosis of TB. So how do you how should one be tested if he is infected or he has got TB disease? So there are 2 blood tests. There are 2 tests available for that. One is the TB blood test, which is IAGRA, and the other is TB skin test. In IAGRA, basically what's being done is that you take the sample of patient blood sample, which is then mixed up with the peptides or the antigens which are derived from the TB bacteria. And in this test, basically, you are trying to gauge the white blood cells response to the TB antigen, and you are basically measuring the interferon gamma release. Unfortunately, false negative results can occur, and most commonly, if the patient is tested earlier within the 8 weeks, because the immune response takes around 2 to 6 weeks. So in that case, it can be falsely negative. The other test, which we all know about, which we had been studying about or reading about from the very earlier days, though it's very less commonly used, is the tuberculin skin test, where PPD, or purified protein derivative, which is derived from the tuberculin, again an antigen, is put in intradermally, and a wheal or a reaction is produced if the patient has immune activity against it. And this basically is a T cell mediated delayed type hypersensitivity reaction. So I will not go into the interpretation of it because that is very detailed and that's individualized basically. So if the patient has the positive test, IAGRA or the TB skin test, then the patient is labeled to have a TB infection. However, for disease evaluation, you need to dig in more into the history. You need to perform radiographs and also the cultures and microscopy. So I would come to the details of that in the next slide. However, if the patient has positive test, but the medical evaluation turns out to be negative, the patient is diagnosed as having a latent TB infection. So how to diagnose genitourinary TB? So you can send smear microscopies for AFP. For that, a urine specimen can be sent, semen specimens, tissue specimens, pus, or discharge or prostatic massage fluids. They can be sent. The good thing is that they are very rapid and they have 97% specificity, but unfortunately, the sensitivity is very low. Then urine cultures, 3 early morning urine samples midstream sent on consecutive days. So the good thing is that they are highly specific. So they are actually the gold standard that we all already know about. But unfortunately, they take a very long time. The standard cultures take around 2 to 6 weeks, and then if you want to know and of course you want to know the sensitivities, they take another 2 to 3 weeks. So a slide dedicated especially to gene expert, because this is something we very commonly advise. So this basically is a nucleic acid amplification test, which is fully automated. It can be performed on sputum and other body fluids. It can be done on gastric liver symptoms, specimens, or pleural fluid specimens also. So the good thing about this test is that it detects the complex, the Microbacterium tuberculosis complex, and also the resistance to rifampicin, and is very quick. So compared to the cultures, which takes around weeks, you can have the report of a gene expert in hours. So determination of rifampin resistance is important because in most instances, when it is resistant to rifampin, it is also resistant to INH. However, it's not recommended for urine at the moment because the data about its efficacy is limited. Histological examination, again, an important part of diagnosis. We, as urologists, we all must have almost done many cystoscopies with biopsies, sending for gene expert and cultures, sending for histopathologies and cultures. Then the next important thing is imaging. So imaging is important in GOTB because the labs, they don't tell you the exact site of the urinary tract being affected and also the impact that it has on the urinary symptoms. So it will help. It is fundamental in localizing the disease and also in gauging the extent of the damage. So this is one very comprehensive slide about the various ways you can see. Let me show you one by one. Yeah. So it's very comprehensively describes the various morphological features that you can see on imaging. So swollen adrenal, adrenalitis, or adrenal calcifications. You can find a thickening of urothelium or papillary necrosis, or you can find blunting of papillas, and also you can see stricturing and papillitis. Then it can also present as perinephric fire standing or an abscess which is ruptured. Then calcified or a puty kidney. Then miliary tuberculosis. In ureters, it can present as strictures. You can see this beaded presentation of the ureter. The pelvis is hiked up here. In bladder, you can find a thick-walled thimble bladder in patients with TB. So a few slides about again a radiological presentation of these diseases. So in this slide, you can see 3 different patterns of kidney involvement. In the first one, you can see a pseudotumor pattern where there is minimal contrast enhancement, there is a minimal perinephric fat stranding. And in this other patient, you can see a pyelonephritis pattern of involvement where you can see a wedge-shaped area of poor a contrast peak. And then this other patient where you can see a renal abscess, and also on the right side, you can see an autonephrectomy done by the disease. So again, a ureteral TB, you can see thickening, you can see calcifications in the system. And in this other picture, which is an axial section and a contrast CT being done here, this shows lobar calcifications. This is actually represents an end stage disease, and that is pathognomonic for renal TB. Another one where you can see a thimble thick wall bladder, again secondary to TB. And in this patient, you can see contrast enhancing collection within the prostate. So this patient had prostatic abscess. So now moving on to the treatment. So for GUTB in general, I'm not talking about MDR-TB in this slide. So the treatment generally is for 6 to 9 months. The intensive phase is for 2 months, and then that is followed by continuation phase for 4 to 7 months. So that depends on the severity and individual patient factors. However, for MDR GUTB, the treatment is a lot more individualized. So it's recommended to use at least 4 drugs to which the strain is susceptible, and it is critical to use combination of drugs to prevent resistance. So there are a number of second-line drugs. We, as urologists, we are not much familiar with all of those. So fluoroquinolones, they are injectables. They are now the newer agents, bedaquiline and delaminate. So I'll talk about those in the next slide also. So typically the treatment for MDR used to be for 18 to 24 months, which is much longer than the treatment for GUTB or for TB in general. However, the guidelines very recently have changed about this. So this slide describes the WHO classification of drugs, of the second line drugs which are used in multi-drug resistant TB. So category group A includes levofloxacin, bedaquiline, and linezolid. Then we have group B and group C. So if you notice it carefully, we can see that fluoroquinolones, bedaquiline, and linezolid, they hold a very important position in the treatment of MDR TB. And it's recommended that all these 3 drugs, they should be a part of a regimen if of course the strain is sensitive to it when you are treating MDR. So these 3 should be a part of it, and then the class B drugs can be a part, should be the 4th drug in the whole regimen. And if you see group C, so you can find that these IV amikacin aminoglycosides, they are now much down in the list and not much advised. That's because of the side effects that they produce, and also because of the limited efficacy. So bedaquiline is and the delaminate, which are comparatively newer agents. So the first one basically inhibits the adenosine triphosphate synthase that basically blocks the energy production of the bacteria. And the second one, it inhibits mycolic acid synthesis, which is basically a component of the bacterial cell wall. And that's how they cause their bactericidal action. So, as I talked about previously, that the conventional treatment for TB, for MDR TB, was very long, for 18 to 24 months. However, the recent data and the clinical evidence which is available now supports the shorter regimen. So, very recently in June 2024, WHO released a rapid communication in which it recommended, based on the current trials, that a 6 or 9 month regimen may be sufficient for patients who have MDR. And the backbone of these treatment is the drugs that I've already talked about, the class A drugs with a combination of class B drugs. And based on that, a 6-month regimen, BPALM regimen, is the preferred option for most patients. However, there is an important consideration that this, again, as I mentioned very early while talking about the MDR treatment, that the treatment has to be very, very, very individualized. And patients who have pre-extensively drug-resistant TB or who have extensively drug-resistant TB, they may still require longer and more complex regimens. So here I would like to conclude my presentation, and we'd be happy to take questions.
Thank you very much, Rana. I think you have very comprehensively covered the subject. It is extremely important that we should not miss the opportunity of treating appropriately the tuberculosis. However, if you get primary tuberculosis disease which is already resistant, then it's something that we need. So it's important, rather than treating patients for 9 months, you do your sensitivities right in the beginning, so that you know which patient is, which patient is not. For the sake of time, I think we should conclude. We have already passed 9 o'clock. So this session or this webinar, along with all the 42 webinars that I've held in the last 2.5, 3 years, are available on the Karachi PAUS chapter website at pauskarachi.org. And you can see this one and all the other previous lectures and webinars on the PAUS Karachi site. So thank you very much to all the presenters who have made a wonderful presentation, Dr. Nausheen Rana, and to all our attendees for their very valuable questions. So have a good evening. See you next month on the last Friday of February.